This is the membrane blue, 0.15%, which is a three-band blue, 0.15%. The three-band blue used in cataract surgery with concentration is 0.06%, and the retina, we use it for 0.15%. It's good for visualization of the epiretinal membrane. Membrane blue dual, which is a combination of the last two, the tri-band blue 0.15%, a brilliant blue G 0.025%, and 4% of polyethylene glycol. It is the same concept of the OVD that was used by cadonazole. The aim is to sink the dye into the posterior pole. So it needs larger molecules, so the dye will attach to the glycol molecules and it will sink down. So is it safe? So this is a recent case series in Taylor and Francis in 2021. The surgery was 25 gauge partial aneuploidy with 0.05% of brilliant blue G. And at that time they used, let me describe the photos first. We can see the RP significant macular atrophy and hypo and hyper autofluorescence. And the picture pre-op, you can see the outer retina it looks healthy around the hole, but it got attenuated and lost post-op. This is 1 week post-op, and those other patients. So brilliant blue G toxicity can be manifested as a result of increased duration of application, repeated application, and dye impurities. Subretinal migration of brilliant blue G dye can lead to outer retinal and choric capillary damage. So this is another case report that's published in Indian Journal of Ophthalmology in 2019. And the paper shows the toxicity when xenon light combined with brilliant blue G. The same almost concept. The outer retina was almost healthy. Here it is a bit attenuated, and the RP as well is atrophied. And this is almost 1 week. We can see the gas reflection or the air still there. So this is an interesting article that talks about blood-assisted internal limiting membrane peeling for macular hole repair. This paper was published in 2009 from Taiwan, and they utilized the autologous heparinized blood for visualizing the iLM instead of utilization of a dye or stain. So after vitrectomy, autologous heparinized blood was applied to cover the macula and to coat the surface of the macular area and the fluid-filled vitreous cavity, and the redundant blood was removed, and the only very thin film of blood was left in the macula. It was almost 32 eyes, varies from stage 2 to stage 4. So this is, we can see here the whole blood was injected over the macula, and then it was washed, the redundant blood was washed, and the remaining is thin film of blood that had good staining to the iLM. So this is a photomicrograph for the same article. They took an iLM and they excised it. They sent it to electron microscopy. You can see this is the iLM and those are the RBCs, so it is stuck over the iLM. So what happened if we did not treat the macro hole? So this is a paper published in 2001 in ophthalmology. Long-term follow-up of an operated macro hole. The sample size was almost 65 eyes. It was retrospective, non-comparative case series from, I think, Pascal and Palmer Institute. And you can see the interval from 1968 into 1993. And they kept follow them for a long time, I think for more than 5 years. So the macro holes that was in stage 2, almost zero after 5 years. They shifted to other stages, stage 3 or 4. Stage 3, 22 of them, the remaining is 13, probably 12 of them is stage 2. And the stage 4 was almost double, which is 43. And they utilized the gas classification at that time. And this is the picture of the patient was stage 2, moved to stage 3, and adults that are the same. So in summary of this article, a long-term follow-up of unoperated full-thickness macular hole demonstrates progression in the hole size stage vision loss, which generally stabilizes the at the 2200 or 2400. A redistribution and reduced number of yellow nodular opacities at the level of the RPE at the base of the hole, and the development of bullseye macular appearance resulting from RPE atrophy. I think that this patient has bullseye pattern after neglecting of the macular hole repair. So, what are the types of the closure of the macular hole? So, this is a study that shows what are the types of the macular hole closure, published in 2003. The study was composed of 34 eyes who undergone an anatomical successful idiopathic macular hole surgery, and they found type 1 or type 2. And the technique was partial aneuploidy, BVD induction, regular ion peeling, and fluid air exchange. They did not determine which tamponade. So type 1 closed without foveal neurosensory retinal defect, and type 2 closure closed with foveal neurosensory retinal defect. So you can see this is the normal foveal architecture, which takes almost the U shape of the foveal architecture. This is the healing of type 1 closure. Type 2 closure is when the neurosensory retina heals into the RPE, and which is like anatomical endpoint after successful macular hole surgery. In conclusion of this study, the larger macular hole tends to result in type 2 closure post-operatively, and the smaller macular holes to type 1 closure. So, what is the duration of the full-thickness macular closure after macular hole repair? When the holes will close. So this is a paper that published in Retina in 2008 by one of the known retina surgeons, Klaus Eckert from Germany, and he conducted a study of prospective study, 33 eyes. Post-operatively, OCT images were obtained in face-down position to minimize the interfering reflection created by the air bubble. So the surgery was partial aneuploidy, BVD induction, ion peeling, and air bubble at the end. So we know that it's difficult to take with the spectral domain OCT to take the cut of the fovea or the retina while there is a gas or air. So he applied face-down positioning, and he did OCT in the first day and second day and the third day, and he adjusted the machine to be fit in face-down positioning to avoid the reflection of the air from the retina. And surprisingly, almost 55% of the patients they close within 24 hours, and then the second day almost 18%. And the third day is 27%. And as we can see, the macular hole was ranging from stage 2 to stage 4. So almost about 90% they close within the first day, within the first 3 days. And this is the picture that he highlighted in the paper, pre-op, and this is day 1, this is day 2, day 3, and this is later. So this is a good paper that talks about the photoreceptor evaluation after successful macular hole closure in adaptive optic study. This is published in 2019. It is an Indian study by Ashish Markan. 3 patients underwent successful macular hole surgery. They studied the cone density, spacing, number of neighboring photoreceptors in 2 degree and 4 degree of eccentricity from the fovea. So all of those 3 patients who were analyzed in 6 months after the surgery, all of them, they had type 1 closure, and the technique was 360 inverted flap technique. So this is the cell density of the operated eye, and he compared it with the other eye, which is the fellow eye. This is density 2 degree superior. So we can see this is after 6 months. In 2 degree there is a reduction comparing to the cellular density in the fellow eye. This is superior, but if we shift it to temporal comparing there is a significant reduction, almost 50% of the photoreceptors, as well as inferior. Yes. But 4 degree of eccentricity from the fovea does not show a huge difference. And this is the spacing. Comparing the operated eye, the spacing is more than the fellow eye, which is the spacing between the photoreceptors. So the postoperative recovery of vision after successful closure of the hole occurs because of the migration or shifting of cells from parafoveal retina toward the center. It is cells nearest to the hole margin at 2 degree eccentricity which shift the most as compared with cells which are farther away. The redistribution of cells occurs to try and achieve normal anatomical arrangement. So, what are the surgical techniques that were popular in the literature? So, starting by this technique that was published in 2007 by European Journal of Ophthalmology by a Russian surgeon, Albatov. And his technique was, he labeled that technique by mechanical compression and joining. It was prospective consecutive clinical trial. He compared 2 groups, Group A and Group B. So both techniques were partial aneuptrectomy with eye peeling, but Group A, he added to them the mechanical compression, and he adjusted the edges of the fovea by a vitreal spatula, and then opposing the whole edges by forceps. It was a prospective consecutive clinical trial, and the result is, so almost 92% they had a closure, varied from type 1 or type 2, and the other group, 88%, almost not that significant, but type 2 closure was seen in the other group, which is without his technique. But if you can notice, the VA is better in the second group comparing to the other group, his group. And this is, he highlighted this OCT. And the other technique by Steve Charles that was published in 2013 in the Ophthalmic Surgery, Laser and Imaging Retina Journal, it was AlQahtani retinotomy for the repair of the large microhole. And it was 25 gauge partial aneuptrectomy, and then after PVD induction, cleaning up the vitreous cortical sheet. 25 gauge curved scissors are then used to make the semicircular AlQahtani retinotomy ranging from 500 to 700 micron temporal to the edge of the macula. The aim is vertical elongation and horizontal shortening of the macrohole and widening of the temporal retinotomy site. And that after island peeling as well. With face down positioning almost 5 to 7 days. So this is one of the patients that he highlighted. You can see the OCT, there is thinning at the RPE, the retina, and breaching the RPE as well, which indicate the area of retinotomy. nasal scotoma in the Humphrey visual field, and this is the OCT pre-open post-op. And the successful rate for his surgery was 5 out of 6, 83%, and average follow-up was 26 months. So the last patient, counting finger, the hole was opened. He did not highlight in the paper the Humphrey visual field result, only one patient. So this is the most popular technique that we use nowadays by the group from Poland, Jerzy Nowrocki and his team, Sofia Makleska. This paper was published in 2010, and the study reports a new technique to improve the post-operative closure rate and functional outcome in stage 3 and stage 4 macular hole. It was a prospective comparative study. So group 1 and group 2. Group 1, which was the regular eyelid peeling, the conventional way, and group 2, his technique, which is the 360 inverted flap. Group 1 was 51 eyes who treated with standard plasmapherectomy, trypan blue staining, and eyelid peeling with air injection. The macular hole closure was observed in 88% and was flat opened in 19%. His technique was almost 98% as a successful rate. One case was a flat open macular hole was observed. So this is the technique. So the iLM is grasped by pinch and peel technique, by iLM forceps, and then creating an edge. After that, lifting the iLM. So the iLM that was facing the iLM was facing the vitreous, lifted up, and then he tucked it in the hole. So it will be like facing the retina. And he did it in 360. And this is the way. At the end, he trimmed them by cutter. So the inverted iLM flap technique have one thing in common. They may induce glial cell proliferation, resulting in the macular hole thinning with proliferating cells that enhance the closure. In healthy retina, neurons are surrounded by molar cells if the retina is detached, or otherwise damaged macrophage-like cells from the vitreous may infiltrate the retina. These cells may activate the molar cells via tissue necrosis. iLM itself contains a molar cell fragment. Therefore, iLM peeling alone can induce gliosis. Thus, if a segment of peeled off iLM is left attached, it may provoke gliosis of both sides of the retina and the cells of the iLM. So the iLM also may be a scaffold for tissue proliferation. In his technique, he used only air. This is one of the technique. It is speeded up video. So after peeling the iLM, trimming the edges of trimming the iLM itself, and then continue the other flap. And the same thing, trimming the iLM and then tuck it, but don't touch the RPE because it would cause RPE hyperplasia and it might prevent the closure. So this is the thing. So what other techniques? So the same group in 2015 they published another paper and they compared this technique with a new technique they called the temporal inverted iLM flap. It was comparative study, prospective comparative interventional study. So their aim, they want to use the temporal part of the iLM to minimize the iatrogenic trauma that's associated with iLM peeling by decreasing the area of peeled iLM. The aim of this study to compare the original inverted flap technique with the modified from where the iLM is peeled. So 43 eyes, the group A, which is the inverted iLM flap technique. And this is the 44, this is the temporal inverted flap technique. And this is the 360 inverted flap. And this is a picture of all utilization of the island. And this is illustration of demographic data and the OCT. So the result, in summary, so he highlighted that the U-shaped closure is better in group B after 1 year, which is the normal architecture of the fovea, which is 71%. The other point he highlighted is decreasing the number of the dissociated optic nerve fiber layer, which is almost, he found, 64%, comparing to the 360 inverted flap, which is 84%. Ellipsoid zone defect and external membrane defects are almost similar. I have video. I need to go outside. So I think you have an issue with IFO. Anyway, the video that I think I couldn't reach it to my desktop. Okay, but it is similar as this illustration. So lifting the temporal verted flap, lifting the temporal island, and tuck it in the fovea. So how about the utilization of the lens capsular flap? So this is a study from Taiwan, 2006. It was a retrospective interventional consecutive case series in about 20 eyes with persistent macular hole. So all eyes underwent vitrectomy, lens anterior capsular transplantation or posterior capsular transplantation into the macular hole with gas and 1 week post-operative face-down positioning. So we can see the hole closure rate is almost 100%, 10 out of 10, and the posterior capsular transplantation, we can see 5 of them only closed, 50%, and 30% partially closed, and 20% did not close. Same thing. I want to show a video, but I think I had an issue.
2016 or 2006?
I think 2016. There is another paper in 2006.
2006? Before the island flap? Yeah. Why would they think about...
No, this is 16. 116. Yeah.
Okay.
We are at the end of the presentation. So this is another paper that talks about the autologous retinal transplant for refractory macular hole. It was multi-center international collaborative study group by Tamer Mahmoud, Sif Charles, and other authors. It was different surgeons, different centers, published in 2019 in the ophthalmology. This is the so you can see here, this is the preoperative, and this is post-operative after almost 6 months, restoration of the external membrane and ellipsoid zone. And this is another paper. And this is another patient as well. So the size of the retinal flap that they used should be approximately 0.5 disc diameter, larger than the size of the macular hole to allow for appropriate handling and positioning. Advocate the use of BFCL before harvest of the flap because it's easier to stabilize the movement and the maneuver into a position under the BFO. An open hole in an eye with high myopia poses the risk of recurrent retinal detachment in addition to contributing to hindered the central vision. The majority of eyes also showed microstructural regeneration of the retina with improved restoration of ellipsoid zone and external membrane. Complete closure was 87% almost. 36 of them, they had improved vision, 41 they did stable, and 21 they got worse. This is another technique that utilization of the human amniotic membrane, like a Canadian study that was conducted in Toronto. It was a retrospective chart review for all consecutive patients with persistent or chronic macrohole from 2008 into 2021. And the closure rate was almost 91%. They range from 67 to 100. So, but no statistically significant improvement in the vision compared with preoperative levels when analyzed to 2 to 6 months postoperatively. The complication that might happen, 23% of patients, full thickness macular atrophy, CMVM, cystoid macular edema, and subretinal oil. And this is the technique. So positioning, which is debatable topic between the surgeons. So this is a paper that published in 2020 by JAMA Journal of Ophthalmology. It was randomized in 185 eyes, 88 they went for face down positioning, and almost 90 of them they went for face forward positioning. This is their data, and this is the visual acuity outcome. In conclusion of this study, the largest series in which this is the largest series in which the multicenter randomization to face down positioning versus more limited liberal head forward approach has been tested for macrohole. In this study, the author did not find significantly different anatomical success rates between the two groups, but they did find statistically significantly better mean visual acuity and face down positioning, and almost they reached to 2080 and 120. That's it. Thank you so much. I still have 2 videos I try to show you.
Thank you very much, Dr. Faisal, for this nice tour. It's a really very nice scientific tour between the articles and journals, and it shows how the treatment and management of macular hole being developed over the years. And now it's a very successful surgical procedure with success rate up to 90% with promising for visual improvement. And there are still areas of debate about shall we put on face down positioning or no. I remember that days we admit patient for a whole 1 week just to be sure patient on following for face down position. I think in the future these things may also be changed with more evidence will be in this area. But I want to ask a question regarding within those frequent techniques, which technique you prefer to do on the first line?
So personally, I usually for large macroholes, I would go for the 360 inverted island flap. For me, I found this technique very successful. I did not have any open hole yet with this technique. I tried the temporal inverted island flap technique. It's not that promising as penned in the paper. So some would be resistant and refractory to close. Face down positioning, I usually keep the patients for, it depends on the size of the hole, 1 to 3 days. and then I keep them face forward positioning. And one time, KKH, they brought a demo for swept source OCT and with Altus. So it was almost 3 to 2 months. And then I said, let me test my patients. So I had pediatric traumatic large micro holes, 2 patients, and the regular stage 4 micro holes. And with this technique, I found it almost close within the first day. Yeah. So I use usually the long-acting gas. Air, you don't rely on air, you need to shave more, specifically the patient is phakic. You might have limited shaving. So I go for like long-acting gas, C3F8, 10%. This is the usual technique that I use.
Thank you. It's interesting. What about if it's failed from the first surgery, those refractive macular holes?
So failed, for me, I wouldn't go for autologous stent transplant or AMT. AMT would, like the hole, the scotoma would be there, but the visual outcome, I don't think it would add a value. Autologous stent transplant, it might have a risk of this hole that you opened and you transplant it into the fovea, it might have a risk of retinal detachment in the future LBVR. So I go with serum BSS, injection of subretinal BSS at the edges of the hole. So trying to elevate the hole and address if there is a gel component in the vitreous, try to shave more and go for long-acting gas and positioning. Yeah.
Thank you. Questions?
Thank you, Dr. Faisal. Great review for subject is evolving every year, and we have new techniques starting to get from just simple eyelid peeling to amniotic membranes to autologous. In the past, we have difficulties to deal with these cases. So when we have macular hole, usually we are getting sick. What we do usually, starting to put one spot of laser in the bit of the hole, aiming that, the reaction might be helped to hold this so not enlarge. Then just effort to put small dots of lasers at the edge of the holes. Then we have autologous, blood.
You're criminals.
Autologous to put it in the holes, and that's help a lot to hold.
Yeah.
So apart from that, let me ask you, what are the most important
Tips.
risk factors for macular hole failure in nowadays? Definitely, we didn't reach 100%, closure.
So from my observation, I think traumatic, chronic.
No, I'm talking about idiopathic.
Idiopathic. Chronicity and presence of other tissue other than the ileum, such as the perifoveal proliferative tissue that's stuck on the edges, so we need to clean it very well. Sometimes it's sticky, and this gives poor prognosis in the closure. And I think chronicity, that is another factor.
The structure of ileum. Did you think that make difference in closures? Because not all ileum the same. In the billet, you find some fragile, some of them are thick, some of them sticky.
Yeah. By aging, the ileum will increase in thickness, but at the same time will be stiff, will not be elastic. So younger patient will be easy to manipulate inside the eye, inside the vitreous, and you can hold the ileum easy. Fragile ileums common in myope, diabetics. I think older patients as well. So yeah.
I had a bit experience with macular hole in Bahjat disease, and actually we did review for these cases in the past, and I regret now to review that result now with the new techniques of ileum. With the technique of macular hole. I found that in the latest years that I do the macular hole in the Bahjat disease, putting in mild no ischemia, and it's not chronic, and they are doing great.
Yeah.
So I would like now Ghana to review all the cases and put it back.
So thank you, Faisal, for the excellent review. I agree with you. I tried the temporal ileum flap for. So I started. First, we used to do complete ileum peel, good success, but when this paper came out, there is this regular delay between adopting a new technique and between the new technique published and adopting it if it showed success. So the natural delay that happens everywhere. So from 2010, 2014, we started doing this 2017. And I elected to go for temporal ILM flap. Then if it doesn't work, then you still have an ILM, so you can go for 360 flap. If it doesn't work, then maybe you can consider something else. So I did the temporal ILM flap for a while. Then I found that the success rate is less than the complete ILM peel. So I said, well, I'm not going to do this anymore. So I switched to 360 ILM flap. Now, if you look at the literature, there is this study from, I think, Manchester, from Manchester. And they looked at the need for ILM flap compared to ILM peel. And and in classification, anything more than 400 is considered large. But they found that the ILM flap made a difference compared to a complete ILM peel in sizes that are more than 650. So if you have a minimum size of 650 microns or more, then ILM flap has an advantage over ILM peel. We had the time where the question was, what is the size of the ILM peel you do? And we used to peel from arcade to arcade and from the disc to the fovea as a diameter. And then papers came out that said less than 3 millimeters is enough. Peel is enough. You don't need to peel more in terms of success. Now, the third comment about the difference in visual outcome in patients with face down and no face down position. I believe the nature of closure with face down is better. If you see that maybe this has accounted for the difference in visual acuity. Sometimes you have a macular hole that's closed, but you see the outer retina is not very in a very good shape compared to some other patients. So maybe this has influenced the outcome. The last comment is there is a paper this week in ophthalmology, and they looked at the timing of macular hole surgery, and they looked at the outcome. And that paper conclusion, I did not read the full paper, so that paper conclusion was the earlier the better. So it gives us a sense of urgency, not urgent that you have to do it, but a sense of urgency in doing macular hole. You remember in COVID times, we used to delay patients, and some of the victims were macular holes, and the delay will affect your outcome in terms of closure and in terms of visual acuity improvement, definitely. One last thing that was not commented is medical treatment. What do you think about medical treatment for macular holes?
There is a paper that talks about small stage 2 micro hole with topical medications. And they utilized the Pris-Forte carbonic anhydrase inhibitor agents, as well as the non-steroidal Macular. They found there is no significant the closure, but for me, I tried it for some patients. They came, we have small micro holes, they did not work. So
I think there's questions here for the spontaneous, closure, which is not related to medical treatment here, because there is small percentage that might have spontaneous closure.
right.
But medical treatment, I think this type of research.
Maybe. We don't know yet. Keep it open, don't close
Maybe if
it.
there is new material,
Hmm?
could be used intravitreal It is nice. But I'm the one who's really fan of using this Macular and Navinac.
Yeah, doesn't work.
And it's not that.
Good network.
Yeah.
There is a lot of big laughter when they came up with this in the meetings.
Yeah, it's the same when macular hole surgery was first presented in a meeting. The giants on retina, they did not accept it. How come two young, recent graduates from fellowship came up with the idea that they can do macular hole surgery? But now it is the most common procedure.
Remember when the occiplasmy came, and we were, wow, it is the one.
Yeah.
What's happened? How will macular hole be closed?
Yeah, that thing was very expensive. If it was
No, but
cheaper, maybe maybe it would have gained more. But it was very 20,000 riyals for an injection that can work in 50% of the time, and well-selected patients. So so you don't have to worry about it. It is bankrupt, obsolete. It's not available anymore.
Last question.
So it's a little comment. So those who used ICG before know that I use it for a short while, then you stop using it. Know that when you shine light and then try to peel the ICG, it comes all in one piece.
Right.
Probably it changes the texture of the item, so it will be easier, much easier. Probably wouldn't be of use when you are doing the inverted item flap. Another thing, they looked into a recent study also. Looked into the macular sensitivity after item flap versus no flap.
Yeah.
Just and they found that those with the flap will have less macular sensitivity on microperimetry. One of the techniques to avoid touching or getting near to the fovea is leaving a donut, which is technically quite impossible to leave a donut coil in. So it will need a very long time and skilled surgeon to leave a donut and just peel the remaining item. It will detach eventually. Regarding the question of Dr. Hassan Adibi, which idiopathic holes have less chance of closure, I think he's referring to, so why do Behjat patients have a poor chance of closure, or Dr. Adibi didn't think of closing them? Because the holes on presentation were flat, there was no subretinal fluid cup, and there were no fluid cysts. Those you look for when you calculate or estimate the chance of closure of the macular hole. So if you have a cup, if you have a subretinal fluid cyst at the edge, then there's a high chance that it will close immediately. Another point is they looked at the choroidal thickness of patients who had idiopathic macular holes, and they compared it to the other eye that didn't, and they found the choroid in those patients was a little bit thinner than the fellow eye. So maybe it has something to do with the perfusion to the fovea or macula. Thank you.
One more comment. Regarding to the ICG, there is still some people using ICG, especially Japanese people. They are using, I don't know, maybe the percentage less. And I found this is the best, that can help the eyelid peeling. Remember that when we use it, immediately we have potential space between the ILM and the retina when we put the ICG. We found that we have space. So I couldn't find any that can do that.
I think this is a biased memory.
What's that?
It is not a real thing. I think it is. I have seen people peeling ILM with this ICG. I think it has less staining compared to the membrane blue that we have now. Membrane blue is
no way,
dual blue.
no way,
Definitely.
no way. The ICG was really sloughing all the whole of the ILM. It is sloughing. For that might be, I believe it is toxic. It is sloughing. Take it out immediately in front of you.
Faisal,
Dr. Rubio.
Congratulations, it's a very nice presentation. So my question goes about these fucking patients that after you do the surgery was successful, so you have a cataract again, and you operate the cataract, and the macula hole reopens. So what to do to these patients? And there is any strategy we can use, like give it non-steroidal anti-inflammatory drugs just to prevent this?
Send cataract anterior segment.
I mean, it's a matter of choice because the patient is happy with the result. Then you operate the cataract, and the patient comes again with the macula hole open, and these patients are really angry.
And we need to address this with the patient, and it depends on what is the size of the hole, is he symptomatic or no, how does it affect his life activities. But yeah, he needs surgery. So there's no already island. So we'd go with subretinal basis at the edges of the hole. I think this would be a good option.
Maybe in the office, gas fluid exchange.
Yeah.
Instead, because it closed with the primary technique, but now maybe it opened. There is no traction, no ILM to have traction, so I think the mechanism is different in terms of why.
Made it open?
No idea. It is the same as what happens in pars plana vitrectomy, post macular hole postpartum pars plana vitrectomy. The mechanism that was thought is that dehiscence in the inner fovea is similar to the hydration theory. Dehiscence in the inner fovea layers and then progression of the macular hole. Maybe with the phaco turbulence, this leads to this dehiscence.
Or closed by island flap. Sometimes the fovea is closed by island flap only, not by the
Thank you, Dr. Faisal. So, regarding the discussion about the temporal island flap versus 360 inverted flap, I think there is some thesis for the residents this year, presented 2 weeks ago in National Guard Hospital, comparing the two techniques. 20 patients, low number of patients, but they found similar success rate. I think it is more than 80 or 90%. I agree. So my little experience with temporal island flap is not as good as the 360 or complete island peeling, but that was that was a study. In National Guard Hospital. The other thing is regarding the topical treatment for patients with macular hole. I think the main difference here is the size of the hole and the etiology of the hole. So if the hole is idiopathic, primary hole, maybe surgery is better. But if it is secondary hole, maybe topical treatment or observation is better. And we know that in traumatic macular holes, the rate of spontaneous closure is very high within 1 or 2 months. Now, my question is, during this comprehensive review, did you find any studies talking about silicone oil in patients with refractory macular holes?
No. Most of the literature was talking about the positioning. Gas would be more superior to oil. Some papers they did not find difference. And some papers they use only air and it's closed. And popular papers. So I think silicone would work as well. Although the buoyancy of the air and the gas is better on surface tension, and this would add more healing. But I think the silicone oil, sometimes in some situations you need it. And for me it might work. Yeah. It will work.
Thank you, Dr. Faisal. I'm sure that discussion will never end despite our macular hole being closed. Thank you.